Okay. All right. Okay, thank you all for joining us this evening. You should all be on mute mode. We will have an opportunity at the end of the webinar for everybody to ask questions. So if you could please just keep yourself muted, that would be helpful to prevent any background noise. So we do thank you all for joining us this evening for a presentation on deep brain stimulation for epilepsy. This is Monica Anzalone with the Epilepsy Foundation of Connecticut. I will be your host and moderator. Tonight we have two doctors from the Yale Comprehensive Epilepsy Center who will be giving us an overview on seizures and epilepsy, followed by an introduction on deep brain stimulation, or DBS, which is a new treatment option for medically refractory epilepsy. I'd like to thank Solomon Yee with Medtronic, who is the developer of the stimulation device, for helping us to organize today's webinar. Yale is a level 4 epilepsy center and is one of the 30 centers of excellence that were chosen to begin using this form of neural stimulation for epilepsy. The Yale Comprehensive Epilepsy Center and its Epilepsy Surgery Council evaluate potential DBS patients and offers a deep brain stimulation support group for patients and their loved ones who have undergone or are considering DBS to treat epilepsy. So at this time, I'd like to go ahead and introduce our presenters this evening. Dr. Hirsch, Lawrence Hirsch, is a professor of neurology, chief of epilepsy and the EEG, and co-director of the Comprehensive Epilepsy Center at Yale University. He has published over 150 original research articles and over 100 reviews, editorials, or book chapters, including several related to brain stimulation for epilepsy. He has won multiple teaching awards. His interests include all aspects of epilepsy treatment, including medications, surgery, brain stimulation, and rescue medications. He was involved in the pivotal trials that led to the approval of both responsive neurostimulation and also deep brain stimulation. We also have with us this evening Dr. Jason Gerrard, who is an assistant professor of neurosurgery, specializing in epilepsy surgery, as well as functional neurosurgery. He is the chief of the functional and stereotactic and neurotrauma sections of the Yale School of Medicine, Department of Neurosurgery. He is a member of the Yale Comprehensive Epilepsy Program as part of the epilepsy surgery team. Dr. Gerrard also conducts both translational and basic science research in a full-time laboratory at the Yale School of Medicine. Okay, so I would now like to go ahead and turn this over to Dr. Hirsch, who's going to get us started this evening.
Great, thank you very much, Monica. So Dr. Gerrard and I appreciate the opportunity to present on deep brain stimulation. It's actually a pretty exciting new treatment we have available now. Still a couple people who are not muted on the call. I don't know if you can, Monica, if you can mute them yourself.
Yeah, I'll take care of that.
Thank you. All right, so let's get started. So first, disclosures. Both Dr. Gerrard and I are paid consultants for Medtronic, the company that makes DBS and is sponsoring today's presentation. I'm also a consultant for NeuroPace, which makes a different form of neurostimulator. And Dr. Gerrard is also a consultant for some other device companies. We might mention some off-label use of medical devices, although most of what we're talking about will be on-label, as this is an FDA-approved treatment for refractory epilepsy. You already heard all this, but keep your questions in mind. You can enter them in the chat if you want, and we'll have time, certainly have time for questions at the end. So first, some background about terminology and epilepsy in general, before going into deep brain stimulation more specifically. So the first, epilepsy is really just a condition in which you're predisposed to seizures. So the prior definition was you had to have 2 or more unprovoked seizures, and this is still the most common way to get the diagnosis. But now the definition also includes people with only 1 seizure if they have definite increased risk of having another unprovoked seizure. And that might be because of something on their EEG or something on their MRI, or a specific epilepsy syndrome. In general, we treat epilepsy with medications, and the good news is that works for a lot of people, but not everybody, and I'll give you some numbers on that in a minute. So the diagnosis of epilepsy does not tell you anything about what the cause was or what prognosis is, and there are many different types of epilepsies, from severe early life onset ones associated with marked impairment of intellectual abilities to people who just have a couple seizures in their lifetime. There are 2 major types of epilepsy, focal onset and generalized onset. So this is a depiction of it. So here on the left, you see seizures that begin on one side of the brain, and usually in one small portion of one side of the brain, and they'll often have focal symptoms while someone is still awake. On the other hand, there's generalized onset epilepsy. So these appear to happen on both sides in a widespread area at the same time, not just one little focus like it might suggest from this diagram. It tends to be diffuse and on both sides at once. And they almost always have some impairment of awareness right from the onset, although not quite always. And I'll give you some of the specific seizure types in a minute. So the deep brain stimulator we're going to be talking about right now is approved for refractory focal epilepsy, although there is evidence that it also works in some of the generalized epilepsies. So as far as seizure types, so in those who have focal epilepsy, they have, these are the most common seizure types. And I wanted to include this because some of this terminology is relatively new. So just as people got used to the simple partial and complex partial, the official names changed. So if you now have a focal seizure with impaired awareness, that's actually called a focal impaired aware seizure, or FIA. It was previously called a complex partial seizure. If you have a focal seizure where you stay fully awake for the whole thing, for example, if just one arm is jerking for 30 seconds, but you stay awake and remember the whole thing, that is called a focal aware seizure, or FA. It was previously called a simple partial seizure. We previously had a term called secondarily generalized. It's where a focal seizure spread throughout the brain and caused a convulsion or a grand mal seizure. That's now just officially called focal to bilateral tonic-clonic. Bilateral meaning both sides. Tonic means stiffening, and clonic means rhythmic jerking. As far as the generalized onset seizures, they're listed here. The absence are short staring spells. Tonic are spells of sudden stiffening that often cause falling. Atonic means a sudden loss of tone. So those is one form of drop attacks. Myoclonic is a big jerk, or it could be a small jerk or a big jerk. Then tonic-clonic, that can be generalized right from the onset. And then there's some other less common types. So that's a little bit about epilepsy and seizure types. Anti-seizure medications, or also known as anti-epileptic drugs or anticonvulsants. We try and pick one of those that works for someone and gives complete seizure control and has no side effects at all. That's obviously the holy grail of treatment. So the good news is that about 2/3 of people with epilepsy will be fully controlled with medication. And the bad news is that leaves about 1/3 of people who have uncontrolled seizures, also called medically refractory seizures. And those are the ones for whom one might consider things like surgery and stimulators. So the definition of drug-resistant epilepsy, this is a formal definition from the International League Against Epilepsy, is a failure of adequate trials of 2 medications. So as long as they were tolerated, they were at reasonable doses, and they were appropriately chosen medications, if you fail to have full seizure control with those, that's considered drug-resistant epilepsy. And this should prompt a comprehensive review of the diagnosis and the management and begin consideration of things like epilepsy surgery. And that should all be done at an epilepsy center. So what are the treatment options for people whose seizures are not controlled with medication? So we have traditional epilepsy surgery. That actually remains the most effective treatment for those who are proper candidates for that, and that the more than half of patients who get epilepsy surgery will have long-term seizure freedom. The rest of these will occasionally cause seizure freedom, but most of the time just cause decrease in seizures, although it can be a pretty dramatic decrease. So there's neurostimulators, there's the vagus nerve stimulator, responsive neurostimulator, and now deep brain stimulators. There are dietary treatments, the traditional ketogenic diet, still used a lot in young kids, and then related less strict versions of that in adults, such as the modified Atkins. There's always investigational medications. Some people have seizures only in certain situations. So either when they're sleep deprived, or they've had alcohol, or they have specific triggers like flashing lights and something like that that is avoidable, then obviously the easiest way to control their seizures is to avoid the triggers. All right, so on to neurostimulation. So it seems a little odd that one would stimulate the brain in order to stop seizures, because really seizures are a problem of too much electrical activity in the brain. But it turns out neurostimulation therapy is really a very good long-term treatment option for many patients. Again, it's specifically for those who are resistant to medications, who are not candidates for a curative brain surgical procedure, or those who have had surgery and continue to have seizures. You'll also hear the term neuromodulation, and that's because it's been shown that doing brain stimulation actually seems to have a long-term effect on brain activity. So it modulates the excitability of brain activity or the function of the brain in that area. So that is called neuromodulations, which is defined as the purposeful modulation of the nervous system's activity by any means, invasive or non-invasive. So these are the three FDA-approved types of neurostimulation or neuromodulation for epilepsy. The vagus nerve stimulator was the first one approved a long time ago now, and still out there. Responsive neurostimulator was about 7 years ago, and deep brain stimulation was approved about a year and a half ago. All right, whenever you see a nice pretty picture like this, it means it's time to switch speakers. So I'm gonna let, this is from Rio, by the way. So Dr. Gerrard will take it from here, and he's gonna talk about deep brain stimulation specifically.
Great, thanks, Larry. So what I'm gonna do is try to go over what deep brain stimulation is and the actual surgical procedure that's involved, the recovery, what that involves, and things like that. We'll go over some of the outcomes from some of the trials that we've done as well. So the FDA approved DBS for treating Parkinson's disease back in the 1990s. So this is something that's been around for a long time. And several 100,000 people at this point have undergone DBS implant for treatment of movement disorders and other indications that continues to expand, such as dystonia. Trials have been done for depression, for obsessive compulsive disorder, and now as of 2018, it's FDA approved for the treatment of focal onset epilepsy. The next slide, Larry. So what is deep brain stimulation? I think it's always important to start at the beginning. So strictly speaking, it's using small currents of electrical stimulation to modify the way that neural circuits work in the brain. So it's a use of a focused electrical stimulation to modify that particular region, but also to modify or have an influence on widespread pathways. So for instance, high frequency stimulation is known to essentially turn off groups of neurons. So DBS was initially thought of as a way to make a lesion in the brain, but to have it be reversible. So you could turn off a group of neurons that were near the electrode. But we now know that It also has modulatory effects on passing neuron axons, which generate these connections across the brain and can have modulatory influences on these connections as well. Next slide. So the indications that go along with the FDA approval, so as Dr. Hirsch pointed out, it's an adjunctive therapy, meaning it's added on. And the study and approval include those 18 years of age or older. Although I will tell you at Yale, we've already implanted one pediatric patient. It's for focal onset epilepsy. It can have secondary generalization, that's okay, either with or without secondary generalization. And as we went through in the previous slides, refractory usually once 3 medications have been failed. And then we'll go over the SANTE trial. The key here is that it's important to realize that these patients that were enrolled in this trial had very severe epilepsy, and they had 5-6 seizures a month that were significantly influenced their quality of life. So even though, as Dr. Hirsch pointed out, it's not nearly as curative as our typical epilepsy surgeries, that reducing that significantly can have a significant change in the patient's quality of life. Next slide. So it's done by placing electrodes in the brain, and then the stimulating device typically goes in the chest, very similar to the vagal nerve stimulator. And it's designed to modulate the brain and involve the circuits or the areas that are involved in seizures. And as I pointed out, it's been used to treat several other neurological disorders as well. Next slide. This is just a picture of some of the hardware itself. On the left, you'll see a picture with 2 electrodes in the brain, which is the case in epilepsy. There's 1 electrode put in each side or hemisphere of the brain, and then these are connected up to the stimulator pack that's implanted into the chest. And then on the right, you'll see that there are some MRI scans of the electrode that's implanted at the tip of the arrows there in the deep part of the brain, in the thalamus, which is where the name Deep Brain Stimulation comes from. Next slide. This next slide, I believe, shows some of the more close-up of the thalamus itself, which is the main part of the brain that contains the nuclei that we're trying to target in order to induce this widespread modulation. So here you see a close-up view of the thalamus itself, which is deep in the center of the brain. And then in the blown-up picture, the very blue part that's sort of triangular shape is the anterior nucleus of the thalamus, and this is the target that we're using in this case to treat epilepsy. Other areas of the thalamus are under investigation, as Dr. Hirsch pointed out, for potential treatment for different types of epilepsy. Next slide. So I put this in there just to, I'm sure that some people have heard of deep brain stimulation. It's been used in Parkinson's disease, but it's also been very much updated, and it's significantly different for epilepsy than the traditional DBS is for Parkinson's disease. Traditionally, with Parkinson's disease, we would use a head frame as shown in the picture. That was our stereotactic targeting device, and patients were under what's called conscious sedation, where they were awake for most of the surgical procedure. As the outline shows on the left side there, we would do the surgery with the patient talking to us. You may have seen some of these videos online where we would do the microelectrode recordings and do stimulation testing before we place the electrode in. And for probably more than some patients, this is a significant hurdle to overcome, to think about having this frame placed on your head and being in a brain surgery operation where you're awake and people are testing the stimulation. It's not an easy thing to go through. But over the last several years, we've developed, next slide, Larry, the ability to do DBS using direct image-guided targeting. Well, what does that mean? Well, that means we can use high-resolution MRI scans if our target is visible. And for epilepsy, the target is visible. This is a sagittal view here. You can see the nose in the far left and the back of the head's to the right. And when we have this type of good imaging, we can see the anterior nucleus of the thalamus, and we can see the dark spots with the red dot there in the middle. That's where the target is for the electrode to go. And it turns out that this location can vary a decent amount from patient to patient. So it's actually, you're better served by seeing the target directly with imaging and then putting the electrode there. So what this means is the patient doesn't have to be awake and interacting with us. We don't have to use the head frame. So patients, the big benefit for the patients is they're just asleep under general anesthesia, which is much better in the case of patients with epilepsy anyway, because the last thing we want is for a patient to have a seizure while they're in the head frame. As you can imagine, that would be a significant issue. Next slide. So how do we do this? Well, in the top left there, you'll see a blow up basically of the previous image that's sort of focused in on that thalamus with the same red dot for the target. And the green area is the part that we really want to stimulate. And it shows how you can create this target and put an electrode in so that you get that desired stimulation zone. And we can do this now with specialized rooms. So in the bottom right is actually also my background. And that is actual picture taken in our operating room, which has a 3 Tesla MRI scanner that is on tracks, as you can see in the ceiling. And what this allows us to do is to get real-time MRI images while we're doing the surgery. So we do actually a significant part of the surgery in the MRI scanner. This is just an idea of how we do this. So on the left, you'll see us actually putting an electrode in. And again, another picture of the operating room itself with the MRI scanner that can come right to the operating room table for us to do this procedure. You'll see on the left picture the apparatus that has the yellow, green, and blue dials on it. And these allow us to do the targeting, which we'll go over, I think, in the next slide. So this system allows us to use the little clear plastic frame that's put onto the head and real-time images to see the target, identify the target, and then align our trajectory to that target. And this is a picture of the software, what we see in real time. And the purpose of the handles that you see in the top right are so that the operator can be standing outside the MRI scanner and still turn the blue, the yellow, green, and red dials to direct the tower right to the target that we want. And then we get real-time imaging to tell us when we've achieved that goal and then allow us to place the electrode exactly where we want it. It's very beneficial for everybody because we get real-time feedback about the placement of the electrode and that it's going to the target as we wanted it. Next slide. So what is it like to go through the surgery and recover from the surgery? Well, typically patients will spend one night in the hospital, typically in the ICU after surgery. Most patients have a pretty good headache that takes a few days to go away, but it will improve and people are discharged home on the day after surgery. We don't make any changes to your epilepsy medications. It takes about a month, I tell patients, to recover from having brain surgery. And we do this in stages. So as you see on the slide, we give 2 weeks to heal from the implant of the brain electrodes and make sure everything is fine from that standpoint. Then 2 weeks later, you'll see the stage 2 surgery, which is also done under general anesthesia. And during this surgery, what we do is now that we're happy that the electrodes are in place and everything's healed okay in the brain, we then connect them up to the stimulator that's put into the chest. And there's what are called extension leads, which are tunneled under the skin to connect the electrodes to the stimulator pad. This is an outpatient surgery, so no additional hospitalization is required. Next slide. And then this is an example of what an MRI scan would look like with the electrodes in place at the target inside the thalamus. You can see the red arrows here show in the coronal or a cross-section view, and then what's called an axial view, which is 90 degrees opposite that. Next slide. So what was the trial? And I think both Larry and I will go over some of the outcome data from what was called the SANTE trial. And anytime you do a big trial, you have to have a very cool acronym. And so the SANTE stood for the stimulation of the anterior nucleus of the thalamus in epilepsy. And this was a blinded and randomized trial that had 17 centers across the United States that were all enrolled. And the key is the blinded phase. So this is a timeline basically of what each patient in the trial experienced. So there was a 3-month baseline period starting on the far left. And then patients had surgery. They were given a month to recover. after the implant, which is very typical for this surgery. And then patients were randomized during the 3-month blinded phase as to whether or not the stimulation was turned on or not. For most patients with electrodes in the anterior nucleus of the thalamus, the patients can't really tell if the stimulation's on or not. They don't really feel anything, or they can't really report back, that went to be able to tell. So this trial was able to do a true blinded phase, whereas most DBS for movement disorders, for example, the patients can tell when the device is on and when it's not on. After that 3-month blinded phase, they opened it up, and every patient was allowed to have the programming done in the 9 months, the last gray block of unblinded phase. And then the trial continued on to long-term follow-up, which is now out to, I believe, a little over 7 years. And we'll go over some of that data. Next slide. So these, the patients that were allowed to be included in the trial all had focal onset of their seizures. Again, they could have secondary generalizations, that was fine. They averaged about 5 to 6 seizures per month. So they had a significant number of seizures. They had a high seizure burden. And they didn't have to have as Dr. Hirsch showed earlier, the picture with one spot that was then spreading throughout the brain. It could be a rather broad onset area as long as it was not completely generalized epilepsy. Of course, they were refractory to drugs, and with most trials we do, the age range is typically 18 to 65. And then the next slide shows the blinded phase. So you have, starting at the far left, the axis is the patient's baseline. So this is based on the % change in their seizure frequency. So what you'll notice is that at the 1 month, so the dashed line, all the patients, and whether they were going to end up being in the stimulation or control group, the stimulation group or the control group, had a significant decrease in their seizure frequency. And we see this commonly with epilepsy surgery, even when we do what's called an intracranial study, where we put a bunch of electrodes in the brain. But then what happens over time without any intervention is that tends to drift back to baseline. You can see that's pretty much what happens to the control group. They drift back towards their baseline, whereas the group with the stimulation on in the green line continued to improve over time, such that at 3 months, there was a significant difference between the groups, with a 40% improvement in the group that was on and only a 14% improvement in the group that did not get stimulation. One of the criticisms of this trial, which I've pointed out, is that this blinded phase, if it had been longer, that difference would have been even bigger because the control group would have continued to go back to their baseline over time. Next slide. Adverse effects, of course, always have to be taken into account, and these are the adverse effects that were listed from this trial. So there were a small number of patients that had some bleeding from putting the electrode in. Fortunately, none of them were symptomatic. You can rarely get symptomatic bleeding from deep brain stimulation surgery, but in this trial, there were none that were. The infection rate was about 13%, which is within the realm of what we see with DBS, so it's on the higher side. To be honest with you, the key here is that none of them were in the brain. So typically people who get infections, the bigger the hardware, the more likely it is to be infected. So these tend to be around the device itself in the chest. 5 people did have status during the trial. 1 of them did seem to be related to the device itself. Other than that, the percent really wasn't that much different from the general population with epilepsy. There were initially some concerns of issues with depression. There were a number of patients in the trial that reported depression, and this was a concern especially in the early part of the trial. With long-term follow-up, however, there wasn't a statistically significant increase in depression. But what they did point out is that most of the patients who got some worsen in their depression with the stimulation had prior depression. So this would give you patients to keep an eye on. The patients who reported changes or decreases, especially in their memory, were all studied. Most of those patients actually were stable on their neuropsych testing, but there were a small 9% of those patients did have some change in their neuropsychological testing. And then importantly, SUDEP, which stands for sudden unexpected death in epilepsy, the dreaded SUDEP did show a significant decrease. So there was 2.9 per 1,000 patient years, which is lower than you would expect in your sort of typical epilepsy population. Next slide. And I think we're ready. I think that's me swimming on the left there, Larry.
Oh, I didn't think of that as a representation of the speakers. But all right, that means we're transitioning over to me. So what about long-term outcomes? So you heard most of the short-term ones and the safety issues and the adverse effects in the long term. What about the efficacy in the long term? So this shows 7 years of results from the same SANTE study. Says how many patients were. This is about 100 patients. And this shows the % decrease in seizures from their baseline. So in this one, the lower the better. So what you can see is that over time, as the years go by, the decrease in seizure, it gets better and better. And by 7 years out, there's about a 70 to 75% decrease in seizures on average. And about the same number of patients will be what we call responders, meaning they'll have at least a 50% decrease in their seizures. So those are quite impressive numbers for 5 to 7 years out from a treatment, much better than we see in any medications. If you look at seizure freedom itself, there were 16% of patients who had at least one 6-month period of complete seizure freedom. And at the 5-year time point, 16% of the patients were seizure free for the last 3 months. So it does happen, but we don't usually suggest people pick this or expect to have a seizure free outcome. So again, it is a minority. Overall, seizure severity and quality of life improved as well, and I'll show you a little bit on that. This one shows the different subgroups. So the one is about where the seizures came from, which lobe in the brain, the temporal lobe or the frontal lobe, whether you had a prior vagus nerve stimulator or not, and whether you had prior epilepsy surgery or not. And now it's reversed, so the higher up, the better. Shows the % decrease again. And basically, you can see in every single group, they all have a major improvement. And it really doesn't matter much whether you're in the temporal lobe or the frontal lobe, whether you had prior vagus nerve stimulator or not, and whether you had prior surgery or not. That all these groups seem to benefit. And this is showing again year 1, year 5, and year 7 for all these subgroups. This shows 2 things. So on the left is a measure of seizure severity. And it's looking again over first 5 years of this trial and comparing it to their baseline. So everything above 0 is an improvement. So there's improvement right from the start, and it continues to get even better over time. And the same thing was seen with this, which is a quality of life in epilepsy scale. So there was improvement right away, but continued to get even better in the 3 to 5 year range. Okay, so that's seizure severity and quality of life measures. There were a couple other important things noticed in this. One was they looked at seizure-related injuries during that blinded phase where patients did not know whether or not they were getting active stimulation. And it turned out there was a seizure-related injury in 25% of the patients who were not being stimulated, but in only 7% of the ones who were being stimulated. And that was a highly significant difference. They also did an analysis of the most severe seizure type for each patient, and they were decreased about twice as much in the active group compared to the group that was not being stimulated. Oh, it's a pretty picture, so we're taking it back to Dr. Gerrard.
All right, so people often have questions about, so what, how has things been going at Yale as far as specifically? So I wanted to give some information on that. The Yale New Haven Hospital, as of now, is the only center in Connecticut that's performed DBS for epilepsy. We've actually done a considerable number of these cases. You'll see the numbers are still pretty small. We've done 7 to date since it was improved in late 2018. Some of that has been due to difficulties in getting insurance companies to cover this new FDA-approved therapy. We tend to spend a good amount of time working with these insurance companies, and things are improving, but it's moving slower than we had hoped. We are, I was pointed out, one of the 30 centers that was identified to roll this out. And we have done more DBS surgeries than any other center in the Northeast. So we've done 7. So we don't have a huge number of patients. So far, we haven't had any patients with neurological complications or symptomatic hemorrhages. We haven't had any infections. Though we do have one patient who has some interesting sensory side effects with stimulation, which you can program around by changing the stimulation program of the device. As far as outcomes, so far we have only 3 patients that have had the therapy on for at least 6 months. So it's tough to really say much without less time than that. And 2 of those patients are responders, meaning they have at least a 50% decrease in their seizure frequency. So far, that seems to line up pretty well with the data that Dr. Hirsch was going over, as far as having more than 50% decrease in their seizures in 2 of the patients. The third looks like about a 30 to 40 decrease. So not everybody gets across that 50% threshold, which is where we describe the patient as having a response to the therapy. Next slide. As far as what happens afterward and how does it go, just to go through the complete timeline for people, and then I think Dr. Hirsch will go over some specifics on the programming. So it usually begins about a month after the surgery to implant the electrodes into the brain. And that's about 2 weeks, as we pointed out, after the stage 2 surgery when the device is put in. So if we go through the complete timeline, of course, many people will be aware that the evaluation and review for epilepsy surgery at a level 4 epilepsy center can take a while. But when the decision is made that they're a candidate for this surgery and the surgery starts, if we count surgery as day 0, then you'll go through the process, usually 1 night in the hospital, home the next day for most patients. Stage 2 surgery is about 2 weeks later. And then about 2 weeks after that, you have your follow-up, and then the stimulation is turned on, the programming is begun. So it's usually about a month between the first surgery and when the stimulation itself starts.
Okay, back to me. I think we only have about 2 more slides. So then there's a chronic programming stage done by your epileptologist, your epilepsy specialist. I'm not going to go over the specific parameters. Those who are interested, these are the settings that are used. In the study, it was done at a 5-volt setting. We actually start much lower, usually about 2 volts in the real world, to make sure it's well tolerated and gradually go up. I guess one thing I will point out is the cycling. So it's initially programmed to be stimulating for 1 minute and then to turn off for 5 minutes. But all these things can be adjusted. We don't know too much about what are the ideal parameters, and that's part of what's going to come over the years, is learning exactly what is the best setting for which type of patient. I just wanted to mention also it comes with a handheld controller that the patient has, where they can press a button to log that a seizure is occurring. They can give an extra stimulation for this. It's just like the magnet for the vagus nerve stimulator. There actually is an emergency off switch if it's causing some adverse effect, and you can turn it back on with the same switch. You can check the battery, the Deep Brain Stimulator battery, using this. And if it's programmed a certain way, you can increase or decrease stimulation within specific ranges with some of these buttons as well. So to conclude, and then we'll open up for questions. So deep brain stimulation is a new option for patients with refractory epilepsy who previously had few options. It's proven effective in medication-resistant focal or multifocal epilepsy. It's well tolerated in general. The effectiveness improves over time, over years. It's associated with fewer seizures, with lower seizure severity, fewer seizure-related injuries, improved quality of life, and possibly a lowering of the rates of sudden unexpected death in epilepsy, probably by improving seizure frequency. And combined with other recent advances in surgery and devices and ways that we record from deep in the brain, we really have something to offer virtually every patient who has persistent uncontrolled seizures. So it's really it's very encouraging and a great time in coming up with additional treatments for refractory epilepsy. We still have a ways to go, but we're excited about it, and it's great to have more options like this. So with that, I will thank you for your attention and for spending the evening with us. And I think we'll open it up to questions.
Everyone has the opportunity to type their questions in the chat box in the bottom of your screen, and we'll go ahead and get those answered for you. Thank you, Dr. Hirsch and Dr. Gerrard, for that very comprehensive presentation. It really is fascinating. All that you shared in just a short time, too. Thank you. I have a question to start. I'm not sure if you can briefly explain the difference between the vagus nerve stimulator. I know a lot of people are familiar with that form of stimulation and may have it currently, or perhaps that's been an option for them in the past. Can you talk a little bit about the difference between the vagus nerve stimulator and the deep brain stimulation?
Jason, you want to take that, or you want?
Sure, I'm happy to take that. So, the most obvious difference is the vagal nerve stimulator is stimulating the vagus nerve, which is outside the brain, and we don't really quite understand how exactly it works. We think because the vagus nerve is a big part of what's called the autonomic nervous system, that the feedback from this stimulation somehow modulates the overall seizure threshold. The difference here with deep brain stimulation is we are directly putting the electrode into the brain, into a targeted region, and modulating that target with deep brain stimulation. That's really the main difference. In the future, something that we think will be helpful for us with the deep brain stimulation is we'll be able to develop the ability to record from these electrodes as well as to stimulate. And so this may help us start to identify seizures through the device itself. And with the vagus nerve stimulator, we won't be able to do that because the electrodes themselves are outside the brain.
And is there a way to explain why this might work for one patient where the vagus nerve did not work for them? I mean, understanding that there's the brain, the electrodes are attached to the two different parts, but.
Yeah, I don't think, and Larry can add to this, but we don't really know, to be honest with you. We don't have enough data yet to be able to identify, the vagal nerve stimulator might work better for a patient versus another patient, especially if they both have partial onset epilepsy. The generalized patients will often have the vagal nerve stimulator first, but patients with partial onset epilepsy really don't have a good way of identifying this one's better than the other. When we look at the data, which can be difficult to compare because they were done different times and with different techniques, it's really tough to say, head to head, which one's better. The long-term data from the DBS trial showed a higher decrease in seizure frequency than the vagal nerve stimulator did, but the trial wasn't done for as long as it was for the DBS trial.
Okay, thank you.
I can just add a little bit on that. So yeah, unfortunately in the vagus nerve stimulator trials, they did not follow them out anywhere near as long as they have for DBS and RNS to have head-to-head. So, but certainly my impression and looking at the early numbers, the efficacy, the effectiveness for decreasing seizures is probably a little better with the deep brain stimulation. And I think the chance of a major benefit like seizure freedom is also greater with the deep brain stimulator. But if you want to talk about indications right now, DBS is only officially indicated for adults with focal epilepsy, whereas vagus nerve stimulator can be placed in kids and can be used for all seizure types.
Okay.
Having said that, there's already emerging evidence, this is off-label, not approved, that it works in kids. The DBS works in kids and works in generalized epilepsy as well, in both the genetic or primary generalized. And there's from a few different countries, there's some preliminary studies in small series of patients with Lennox-Gastaut syndrome, or the more severe epileptic encephalopathies, where it can have significant benefit. In the very small trials, nothing near as big as SANTE yet, but we're hopeful that it's going to be effective in those groups as well.
Great. We do have a few good questions here. One, in reference to the 3 patients that you had with the 50% decrease, were they on epilepsy medication during those years? And if so, the same dosages?
So our usual policy is not to change any medications in the first year or so after any stimulator or procedure. So I'm pretty sure Jason will say they're all probably the same. And we only have short-term follow-ups, and nobody's even a year out. I think the 3 of them were past 6 months. That's all.
Mm.
Yeah, so I'll just agree. So even when we do traditional epilepsy surgery, and we have a patient who at 6 months after that surgery is not having any seizures, we still maintain the same seizure medications at the same doses until, as Dr. Hirsch pointed out, at least a year after the surgery.
Okay. And this is an interesting question. What are the electrodes made of, and does it activate metal detectors? And second part, what other hospitals do DBS, and which hospital has done the most of this type of surgery?
So the first part, I can't tell you the exact percentages, but it's a metal alloy that's very commonly used in. Usually we often use platinum iridium for electrodes. They make a good, and they're an inert metal, if you will. So I couldn't tell you the exact composition of the different metals that are in the electrodes themselves, but that's typically what's used. Patients can sometimes set off metal detectors. It's more about the IPG or the stimulator pack in the chest than it is about the electrodes. It depends on how sensitive the metal detector is, but it's not an issue as far as travel. I have hundreds of patients with DBS, never had one with an issue with travel, going through security places or anything like that. The one restriction you do have is being around very strong magnetic fields. And this is a strong enough field, it's nothing that's going to be in your house. It really only impacts patients when they're having an MRI scan done.
Yeah, so there's very special precautions for getting MRIs, and it would be turned off during the procedure.
Yeah, you can get an MRI scan, it just has to be done in a certain specific way. As far as other hospitals, I'm not aware of any other hospitals in Connecticut that are doing this surgery. There are some hospitals in New York and Boston. As far as the Northeast region, we have done the most DBS for epilepsy of any place in the Northeast region. There are, several institutions that do a significant number of DBS surgeries. We're actually in the top 5 for all types of DBS in the Northeast as far as the number of DBS surgeries that are done. There are some very busy centers in New York, as you might imagine, that have a higher concentration of, or higher patient population as far as DBS for movement disorders. So there isn't one in the Northeast that's done as much as we have at Yale so far.
Go Yale. Okay, another question. So the 7-year stats showed, assuming that they were either VNS or from another country, since the FDA didn't approve this until 2018. Is that correct?
That was all from the SANTE clinical trial. So that the clinical trial is what led to the FDA approval. So that was all part of research trials before it was approved.
Okay. And with the 7 surgeries that you've done so far, have you had many issues with insurance companies covering this?
We have. We have probably 40% of our submitted, 40 to 50% of our submitted surgeries get denied. And we have to go through the process of, what are called peer-to-peer phone calls or appeal letters, sometimes both. And, sometimes it can, I always, when I meet with patients in clinic, I will often tell them, you might have to be patient with us. This might take a little bit of a while to get this taken care of. It is definitely gaining momentum. And now that it's been around for a while, we're seeing an increasing number of insurance companies that have a favorable coverage.
Are they eventually covering it if they are denying it, or if it's taking months for them to approve it? Will they eventually approve, or is it just depend on the company?
It depends a lot on the company. we've done several off-label implants already, which are not FDA approved, and they've gotten approved. And so there is definitely a lot of variance. So far, I don't think we've had anyone that in the very long term didn't eventually get approval, but we've definitely had some that have taken months.
Yeah.
Multiple appeals and you know, multiple go-arounds.
And I just have one more question about side effects. So I know with the vagus nerve, sometimes it can, you know, present some change in voice for some people. And from what I understand from the presentation, it sounds like you just said that depression be one of the side effects. Were there others that I missed or anything additional that you were?
Yeah, so I don't know, Dr. Hirsch can say if he's seen anything different, but one of the things that is been noted with this particular brain target with deep brain stimulation is it really doesn't create in general any side effects. In fact, the patient I mentioned with the stimulation sensory side effects has a different thalamic target, so it's not the anterior nucleus. So sometimes if your target in the thalamus is close to the sensory nucleus, you can create these sensory sort of tingling sensations that patients can sometimes have. We see it commonly when we do this for tremor, for example. So patients typically can't tell when these stimulators are on or off, as I mentioned, which makes it helpful for a blinded study. There was some concern that there was an increase in the number of patients that were in the stimulation group that were reporting in a worsening of depression. So that remains something that we monitor. But over the long-term outcomes from that study, there wasn't a significant increase in depression, but it is something that we do keep an eye on. Especially, the one thing they did point out is if the patients have had a history of depression before, that it was more likely to be an issue for them going forward.
Mm. Okay. All right. So I know we're kind of running out of time here. I just have, is that okay if we take just a few more questions before we close?
Sure.
Okay.
People can always drop off when they need to.
Okay. So I guess this is back to the insurance. Of the ones approved, any significant things that made a difference in insurance approval? So for example, age, amount of medications that they've tried, et cetera?
No, not really, to be honest with you. It really seems to just be the luck of the draw who picks up that, you know, that what we call prerequisite approval from the insurance company. Like I said, we've had a handful of them that are off-label that have gotten approved, and some of them that are completely on-label with the FDA that we have to fight months and months to get approval for. There definitely is certain companies that are more likely to approve it, and others that are less likely to approve it. But I really can't tell you that there's, you know, any patient characteristics that make it more or less likely.
Mm, okay.
It's much more about the insurance company than the patient.
And does the state insurance, do you know, cover or Medicare cover?
So Medicare does cover DBS, and there has been some Medicare. So most of our, you know, it's a little different with the Parkinson's population. A lot of those patients are on Medicare. Epilepsy in general tends to be a younger population, but they do have coverage for it, and that's one of the things that we're using. Once you have coverage for things like state programs and Medicare, that's often what we use to convince private insurers to cover as well.
Okay. And has anyone had to have the electrodes removed after having the surgery for whatever reason?
That is very uncommon. None of our 7 patients have had to have the electrodes removed. I do a lot of deep brain stimulation surgeries for movement disorders as well. And only on very rare occasion, maybe once or twice, I've ever had to take the electrodes out.
There were a handful in the original trial that had infections that led to removal.
Yeah. So that's most commonly an infection. And those infections, at least in the trial and in my experience, they're typically not in the brain. But if any part of the electrode, you know, even under the scalp, gets contaminated, the safest ways to take it out.
Mm.
Otherwise, the concern is that that infection can stay on the hardware and hide from the body's immune system and spread.
And in the trial, none of those were in the brain. None of those infections.
Okay. And I just received something from Solomon saying that DBS is approved with Medicaid, specifically with Medicaid in Connecticut, so that's good.
Oh, thank you, Solomon.
Yeah. All right. Some really good information. Thank you. A lot of questions. So I guess that was the last question. I just want to let everyone know that this has been recorded today and will be provided on our website for you to listen to again or to share with others. You can go to epilepsyct.com to take a look at that. And this will probably be put on our website, I'd say as early as tomorrow. So on behalf of the Epilepsy Foundation, I'd like to thank Dr. Gerrard and Dr. Hirsch for taking the time this evening to talk with us about deep brain stimulation. And I hope this was helpful for everyone and that everyone is healthy and safe. Thank you.
Thank you,
Yeah.
Mark, for having us.